Good afternoon, everyone. We are live. Welcome to the California Immunization Coalition Education Hour. My name is Eugene Baronella, a member of the Education Committee and a UCSD contractor coordinating education, training, and outreach activities for the San Diego Immunization Program at the County of San Diego. The CIC hosts education hours throughout the year on immunization-related topics to help our colleagues stay up to date on important news and information. Today, we will focus on the current hepatitis A outbreaks throughout California. We have 4 objectives. The first is to describe hepatitis A modes of transmission, morbidity, and mortality, then describe the unique characteristics of the California outbreak. Next, identify strategies that California counties have employed in response to this outbreak. And finally, identify strategies to increase hepatitis A vaccination. The the education hour is hosted on the ReadyTalk platform. We have muted all participants except the presenters, and you can listen through your computer or through your device's audio channels. A recording will be available from today's slides as well as posted on the CIC website, immunizecalifornia.org. Throughout the presentations, you may ask questions by typing them into the chat box at the lower left-hand corner of your screen. After that, you can select which of your audience will receive the chat. Now, today, we are very happy to introduce 2 presenters, both of whom will have their detailed bio on the CIC website, and both of whom have worked together as colleagues at the New York City Department of Public Health. The first presenter is Dr. Sayone Thihalolipavan. He is the Deputy Public Health Officer in Public Health Services at the County of San Diego. He will be followed by Dr. Sharon Balter, who is the Director of Acute Communicable Disease Control Program at the LA County Department of Public Health. We begin with Dr. Thihalolipavan. Dr. T, the mic is yours.
Thank you, Eugene, and good afternoon, everyone. I appreciate that you all are checking in and using your lunch hour for many of you to really listen and hear us, and hopefully questions going forward on kind of how us and Sharon on LA's end are dealing with hepatitis in our backyards. And thank you again for all your efforts, especially now this time of year during flu season, where we know that where we're reminded annually the importance of addressing vaccine-preventable diseases. So as you heard, I'm the Deputy Public Health Officer for the County of San Diego. For those of you who may not be familiar with San Diego, trying to advance my slides. That we are the 5th largest county in the United States. We have a population of 3.2, now about 3.3 million, and we're about 1% of the nation's population. We are a very large county. We have 18 incorporated cities and a large, vast unincorporated area with 18 Indian sovereign nations, a very large military presence, and the world's busiest border crossing. So and I would also add, that we're a popular destination for a lot of homeless individuals, and I would too if I was homeless. Just to give you a background on hepatitis A, many of you are probably very familiar with this, but it's a virus. It can spread easily from person to person, can cause liver disease, typically lasting a few weeks, but really can last up to several months, and in some cases it can cause death as well. Okay. Overview in terms of the hepatitis A virus, that there is also a long incubation period that makes it challenging to address outbreaks of hepatitis A, and that's that, I can get exposed today but not come down with symptoms. If I do come down with symptoms, up to 50 days later, and on average 28 days. The virus can live outside the body for months, depending on environmental conditions, which is especially important to consider when we have folks like homeless individuals affected and being spread in places like homeless encampments, where you have to consider the sanitation of the environment. And then you can be an individual who's contagious, can be contagious up to 2 weeks before developing symptoms, and really up to a week after, as per CDC. And there's some literature suggesting that might be later than a week as well. We know you don't have to worry about it in the public water supply. Chlorination and other public water treatment efforts typically kill the virus. And as you all know, a full dose of two-dose series of the vaccine is the best way to prevent infection. We know that it can be spread just by the oral fecal route, and really just ingestion of even a minor and microscopic amount of fecal matter can get someone contaminated. We know that the most popular mechanism of spread in the United States that the CDC reports is that close person-to-person contact, but it could also be spread through the food supply, using recreational drugs, and sexual contact. Then what you have in front of you on the next slide is really the symptoms, and you see the top row is really the non-specific symptoms that acutely start when you get hepatitis A, and then after that, acute onset of fever and the symptoms. For those who get those symptoms, about 70% of adults experience jaundice, and then there's also stomach pain, vomiting, and dark urine, which they refer to as Coca-Cola urine sometimes, and pale or clay-colored stools and diarrhea. And so not everyone gets symptoms, but some do. The next slide shows really the significance of vaccines, and if this isn't a reminder of how powerful and wonderful vaccines have been to public health, then I don't know what else would convince you. But really showing a couple decades ago the incidence of hepatitis A, and you see that kind of higher incidence in the western part of the country, and California particularly being a high incidence state, and then just up until 2007, you see that there's more parity in terms of the incidence across the U.S., and the only significant change that contributed was really the vaccination that had come out. And so when we look at our San Diego cases, we see that in 1995 the vaccine was introduced, in 95 and 96, and then in 99 it became a routine vaccination recommended for children in high incidence states, as well as other populations that I'll talk about. And then in 2006 it became a routine vaccination for all U.S. children. And our cases, just like throughout the rest of California, dwindled, and we decreased about 95% of our cases, to the point where, up in 2015 and even earlier parts of 2016, what we were routinely seeing as hepatitis A cases were typically people who traveled to other countries where it was more endemic, came back, and because of that long incubation period, got sick here in California. But what we noticed in early March of 2017 is that we noticed an increased number of cases of hepatitis A, and when we looked at our demographics of who was affected, we saw that it was primarily homeless and drug-using individuals, and we saw that cases were tied back from late November, where we had a trickling of cases, and I'll share the case curve in a little bit. And then what you see in front of you is that you see that there's maybe a little bump in 2016, and then really we see it in 2017. You see that significant bump, and we're back at essentially the mid-90s levels of the amount of hepatitis A cases that we had back then. And this is showing all of our cases, outbreak and non-outbreak cases. When we look across the country, we are currently the second largest outbreak of hepatitis A since the vaccine was introduced. So you see that the first one was a food-related outbreak, 660 cases from contaminated green onions from Chi-Chi's restaurant, with much relatively lower death rate. And for us, we're at 567 cases with a 67, two-thirds hospitalization rate and 3.5% death rate. Michigan is unfortunately right behind us and probably will supersede us in a few weeks or a week. And they have a little higher hospitalization rate and similar death rate. They are also being spread by close person-to-person contact. And one of the concerns of what recently happened in Michigan is that their outbreak went from being primarily in the same populations that are disproportionately affected here in San Diego and homeless and drug using, now to being kind of jumping and spreading more and crossing over into the MSM, or men who have sex with men population, who has also been a long time CDC identified risk group who should have been vaccinated, frankly, before the outbreak. So we're trying in San Diego to make sure that that crossover doesn't happen here as well. Okay. So where we are now is 567 cases. I already mentioned 2/3 hospitalization rate. We have about 2/3 males being affected. We have one child, that 5-year-old, in the age range that you see there, and that 5-year-old was not immunized previously. But otherwise, this is primarily an outbreak in San Diego that's affecting adults. Other than that one child, we have. When you look at the types of individuals who are affected, 32% are homeless and drug using, 16% are homeless only, 12% are illicit drug using only, 29% are neither, and 11% have insufficient information to classify. And of the neither, about 50 or so percent are tied directly to the homeless and drug using individuals, either by working with them closely, volunteering with them, or spending time with those groups, but not self-identifying as one of those groups. We know that about 22% of our cases that we have lab tests for Hep B and Hep C also are positive for Hep B or Hep C, which is important to note because these are also individuals who have chronic liver disease and also would have met the long-standing CDC recommended groups, should have been vaccinated before the outbreak. So, and I mentioned this only for constructive purposes because we know that we're doing a great job with childhood immunizations, but we know there's always opportunity to improve with adult vaccinations. And what you all could do if you're calling in from different parts of California is really work with your healthcare community and make sure that those who've been recommended to get vaccinated for a long time now, for decades now, should be vaccinated, and making sure they're really doing that. And we're doing that, of course, in our backyard as well. And we have 37 cases during this period that also meet the non-outbreak, that meet CSTE criteria but are not outbreak related. We have 6 under investigation, and we have cases that are linked with our genotype that are in other California counties, as many of you know, Arizona, Kentucky, Colorado, Rhode Island, and Utah. This is our epi curve, and you see that kind of trickling in that I was referring to from the end of last year. Really, it wasn't until early March where you see the numbers started increasing on a week-by-week basis, where we determined that the number of cases coming in and were higher than what we expected, and met our surveillance thresholds to set off alarms and for us to look into more closely. And then you see that the numbers rose, and we're staying about the same for several weeks, and thankfully now we're seeing a kind of a sustained decline. Because of that long incubation period, we know we have to remain vigilant. We know we have to keep addressing this in terms of vaccination, sanitation, and education. And we have not either declared the emergency over or declared our outbreak over yet. We have on our website maps like this where more detailed in terms of which parts of the county are more affected by the cases, and numbers, as you see, of our vaccine field events, and our total vaccines administered, which has been over 108,000. And so our 3-pronged strategy is to vaccinate, sanitize, and educate. We're working really closely with our Department of Environmental Health to make sure it doesn't get into the food supply, by educating a lot of the food providers, by vaccinating some of them, declared a local health emergency, and as you all know, the state declared a state of emergency in October, and continue to work up all the cases. And it's a lot of work. This is by no means any individual effort. This is really a community-wide effort and a lot of effort within the county, and we were relying on many of our partners, which I'll talk about at the very end. So our challenges that we've seen to date really have been mostly in these buckets. The disease-specific ones, as I mentioned, the long incubation period is really hard. You don't get that instant feedback like you do in a norovirus outbreak or something like that, where you can address it more rapidly and you get that data more rapidly to address things quicker. And then there is this infectious period before and after symptom onset, which especially is challenging for individuals who are homeless or undomiciled and, for example, get discharged from the hospital but don't, because they're medically stable, but they don't have they go back to the encampment and then they're continuing to spread potentially continuing to spread hepatitis. We know the hand sanitizer is not as effective for hepatitis A, so hand washing is extremely important. And that is not just for homeless, but a lot of us have been used to using hand sanitizer, including even some of our healthcare partners. We have to remind them that, hey, we know that you have hand sanitizer readily available, but remember to wash your hands really for the best protection. Relapse for hepatitis A is an issue, and in the literature there's a span of 3 to 22% relapse rates that have been reported. We're seeing closer, I believe, as to a 15% relapse, but that is an issue, and that's something that we've had to educate our providers about. In terms of the populations disproportionately affected, the homeless and drug-using individuals, we know that these are difficult to reach populations. When we get them, they may not accept the vaccines. We may not be able to. They might not be able to go to one of our existing vaccination sites, even if they are really close. They don't want to leave their belongings outside, everything they own literally, and go into a vaccination site and at the risk of someone else taking their belongings. And other examples, of course. And then they may not have access to sanitation, hand washing, and things like that. Other challenges is the low vaccination rates amongst adults who already have existing CDC indications. None of our cases have reported having the full two-dose series of the vaccine. We know that I mentioned this problem with isolating discharged medically stable yet infectious homeless individuals. We know there's a potential of crossover into other populations like men having sex with men or the general public, as mentioned, with trying to making sure this doesn't cross over into the food supply. And, of course, risk communication is always a challenge because you want to address the worried well and reassure them because it's an oral fecal disease and fecal oral, and it's not, as contagious as something like, like, for example, what happened in Disneyland a few years ago, where you can literally walk in, not know people who you're close to, and get exposed to other diseases, respiratory diseases, but like measles. But as long as they're vigilant, that they can protect themselves from hepatitis A if they're not having, and they may not need a vaccine, especially when there were questions earlier on about vaccine supply, but a lot of people were hesitant to do things like volunteer around the holidays, volunteer for our annual point-in-time count because of concerns about getting hepatitis A. So a lot of communication has emerged since then to really reassure those kind of quote-unquote worried well who are at much less risk than those of us who may work closely and routinely on an ongoing basis with homeless or drug-using individuals. So we've vaccinated over 108,000 individuals, and we've enhanced our efforts at medical institutions and public health centers, immunization clinics, but then we've also newly done other efforts where we've gone to jails, vaccinated people during intake and their inmates, and going to our substance use treatment programs, going to our homeless service providers, going to SROs where they're housing unstable individuals, going to encampments, literally having people out in the field going out with coolers and vaccines, and EDs. Emergency departments don't often do this, type of thing. So it did take a lot of effort, and they've been wonderful partners. But it did take effort to introduce this new workflow for them to do it. And it was critical that they do that because they have access to certain individuals that otherwise may not get hospitalized, and they might get to in that the few hours that they have them before they maybe discharge them from the ED, where they could offer a vaccine to other people who we might otherwise not see. I would just want to emphasize the use of the immunization registry has been extremely helpful in all of this. Where our nurses in the field are able to check on their phone in real time, whether or not John Doe has been vaccinated or not, and then before they administer a kind of redundant shot. That said, we have had a few redundant shots given, but we've definitely minimized that with the use of this and the use of education about the registry. And all of the data from health centers and from hospitals and outpatient clinics and outpatient, FQHCs and EDs, that's all going into our registry, as well as the vaccinations that, of course, we provide. And I would know and want to also highlight our local health information exchange, which we use to get seamlessly the data that's given. So at the hospital level, if someone puts in a vaccine, it goes into their EMR. That info is automatically pulled through our local health information exchange and into our immunization registry. So we've also had to expand vaccination capacity, of course, as we mentioned, working using ED providers, in addition to our county employed nurses, we've used our behavioral health county nurses as well, our contracting nurses, our temp nurses. We've activated our local medical reserve corps nurses as well. I mentioned medical community pharmacists play a wonderful role. They're especially great for those like the worried well or people who are have the ability, have the insurance coverage, who can go to them more easily. Our local medical society in our county has a foundation which pulls in volunteers, and they're able to set up their own vaccination events. We just provide them with the vaccine and kind of help direct them to who to give the vaccine to, which is the at-risk folks. And paramedics, we've locally expanded the scope of practice for paramedics to administer a vaccine. They have to first go out with nurses, and then after enough time where we're comfortable and they're comfortable, they don't have to go out with a nurse. And of course, more important probably at this time of year is flu vaccinations, and these are very vulnerable populations, and so we're coupling our efforts with flu. I'll just quickly go through the last few slides. We're doing sanitation efforts, and we've provided guidance on that for indoor and outdoor sanitation efforts, just to make sure they're using the appropriate chemicals to kill hepatitis A. And outdoor sanitation, we've borrowed from the City of LA's model and adapted for local purposes, and also for hard surfaces. For soft surfaces, our county, our unincorporated area has a lot of soft surfaces, and they've produced a document for that too. We've worked with the jurisdictions to place hand washing stations where otherwise there's not access to that hand hygiene, specifically for hepatitis A, since we know hand washing matters. These are temporary. And then, of course, work with the jurisdictions and the cities to really expand their public restrooms and encourage them to do so. We've also developed hygiene kits that we give to our partners to encourage them, the homeless and drug-using individuals, to accept vaccination. And done plenty of education, news stories, press conferences, health alerts from almost like day 2 or 3. We had to get on the phone with CDC to expand locally our recommendation for who's vaccinated, and we expanded it to homeless individuals because they're not on the CDC current recommended list. And then in addition to expanding to homeless, we also expand to those who work closely and routinely and or clean up after homeless and or drug-using individuals as well, because of the cases that we saw in folks kind of in that next ring around the population most at risk, which is homeless and drug using. And then we made a local recommendation for food handlers to be vaccinated, just to put another ring of protection, around this getting, further or spreading further than it currently did, and getting into the food supply. So we've done all these education events, as you see, and we have flyers, FAQs, et cetera. If any of you want the source documents, we're happy to share them with you, and we have shared them with a lot of the different jurisdictions. And we're routinely educating food inspectors when we go out and do our food inspections as well, and created guidance for the volunteers, like I mentioned earlier, and we have specific efforts targeted towards kind of churches for volunteer efforts, and also for men having sex with men population to make sure to try to prevent that crossover. For medical partners, we've convened the medical partners. We had a high-level meeting. We've talked with the CEOs and the executives. We had a meeting with the mayor of San Diego as well, and with the medical leadership, and we're continuing to work with them very closely with our San Diego Disaster Healthcare Coalition as well, and just reminding them of things like active reporting, calling us, not waiting for the lab to report. We will interview them in the ED, even if they're only a suspect at that point, just because sometimes we lose them to follow-up after that if we don't get a hold of them there while they have them kind of quote-unquote captive. And then, of course, working with them to vaccinate those who are already recommended by CDC and the new population at risk from this outbreak, making sure that they check the registry before vaccinating to avoid duplication, to use our process that we established when they have someone who's medically stable but ready for discharge, use our process where we offer them temporary housing so that they're not going back infectious and spreading it back into the encampment if they're homeless. And of course, reminding them to use standard precautions, use hand washing, etc. We do part of our public education. We have maps online. We use 211, our non-emergency hotline, to take a lot of kind of the quote-unquote worried well calls, and which have minimized as the outbreak has gotten better. And really, I just want to leave you with that it takes a village. I mentioned already really multiple internal county departments and external people, whether it's our medical providers, society, hospital association, HIE, all of our homeless service and behavioral health providers, of course, all of our cities, and plenty of other local partners, as you see here, whether it's a restaurant association or Chamber of Commerce or 211, and of course plenty of state partners. We rely greatly on the state. We talk to them significantly, even on things like, for example, the California Department of Pesticide Regulation, because the ability for streets to do that sanitation that they need to, for cities to do that street sanitation that they needed to, we had to be able to expedite that review and approval process by the state, so that way our city of San Diego most specifically was able to use the proper chemicals, which is a bleach solution essentially, in an expedited fashion and not wait for the kind of the usual approval process. So we've relied on a lot of folks, and we also are relying on CDC. We're continuing to work really closely with them, and them even continue to do modeling with them, and then working with the Housing and Urban Development Group, which funds a lot of the homeless service providers in this county. So thank you, and with that, I'm going to hand it over to Sharon Balter, who's my former colleague, and she's, as mentioned, she's the director of Acute Communicable Disease Control Program at LA County Department of Public Health.
Hello, thank you, and I'm just trying to figure out how to advance the slides here, actually. Right. Wait, oh no, there we are. Okay. Let's see. Okay, so I wanted actually to start by not only thanking everyone listening, but by thanking Sayone and San Diego in general, because I arrived here in late July. I've been dealing with an outbreak of hepatitis among MSM in New York, and I was aware of the outbreak in San Diego, but kind of vaguely, and it seemed very far away. And then I got to LA, and it didn't feel so far away anymore. And I feel like San Diego, as they are today, has been incredibly generous in terms of talking to us about their experience and helping all of us to prepare. And they've also generated a lot of really interesting data that I'm very excited to have them write up. So Los Angeles is, I believe, the largest county in the U.S. We have more than 10 million people. 25% of Californians live in LA County. We're also very large, 4,000 square miles. I haven't even been to every part of LA yet, which would be larger than Rhode Island and Delaware combined. The population density is relatively high, 2,420 people per square mile. We have the highest number of millionaires and also the largest number of homeless people of any county in the U.S. So it's estimated that we have 57,000 homeless spread over the community, and as I believe in San Diego, we also have these very, very large tent encampments, which were new to me because on the East Coast, people can set up a tent, but eventually it gets cold enough that everybody has to go inside. We also have smaller sites, and I think that because we are so close to San Diego, and Santa Cruz also had an outbreak I think I arrived at a moment of very, very heightened concern about spread. There's a lot of travel between the jurisdictions. Then in addition to our homeless community, as Theo mentioned, there is also a very high rate now among men who have sex with men, and we have more than 400,000 men who have sex with men in LA. So just overall, as I think with everywhere, there's a very heightened concern about hepatitis A. As with most jurisdictions, our rates have been fairly low in the last decade, about 40 to 60 cases a year, again, probably because we were vaccinating children, but because we only vaccinated 1-year-olds, we still have a very vulnerable population among those who are over the age of 18. So our highest rates have generally been in those who were 35 to 44. And although we had a small outbreak among homeless about a decade ago, in recent years we've had no cases among the homeless. So we did declare an outbreak this fall, and to date we've been very lucky in that we've only had about 15 associated outbreak cases. It started in June and July with a case from San Diego who went to a board and care, and LA, the folks in LA, was actually before I came here, were able to quickly vaccinate everybody in the board and care who would accept the vaccine, and there was no spread there. And then there was one patient who went to a mental health facility, and there actually were 3 secondary cases. So there was a small outbreak in the mental health facility. The patients were allowed to interact, and so it wasn't so much nosocomial spread as we usually think of it. It was direct interaction among the patients. We did vaccinate all of the contacts there, and there was no additional spread beyond that. Beginning in September, we started to have cases from San Diego and Santa Cruz who arrived by bus and reported to us that they were living on the streets. And we had one case who was released from a jail in San Diego and briefly worked as a food handler cutting fruit in LA County. And these cases definitely raised our anxiety about spread. A lot of the cases had a history of mental illness, and they really couldn't tell us where they were living, or they would describe the bus route they took, and it wouldn't be a bus route that existed. So it made us aware that there could be ongoing spread, or that it was going to be hard for us to get to all of the contacts. And then we started to see a couple of cases who reported no links to San Diego or Santa Cruz. So it was clear that there was at least a small amount of spread going on here in LA County, and that's when we declared an outbreak. And I will say, actually, just going back to that, I'm really glad that we did declare the outbreak when we did, because I think Theon described the great effort that everybody has to go to, that it's that it really takes a village. And mobilizing that village is very, very hard without something like an outbreak to do it. And although we're no longer in quite the acute ICS mode we were at the time, sort of getting the nurses together, getting the coolers to go out onto the riverbank encampments, just getting everybody on the board engaged in the idea that we needed to do this and that we needed a lot of vaccine was really hard. And I think the outbreak declaration really helped with that. Not surprisingly, we are also beginning to see an increase among MSM. We have 19 cases to date this year. We had 9 in all of last year. And as discussed, there's a special risk among MSM. They've always been recommended to get the vaccine. People who are HIV positive may have longer courses of illness. We have seen patients who are HIV positive, which always seems like an incredibly missed opportunity for prevention, since most of them are in care now, and they can have increased viral loads. Sometimes they have to stop their meds because they're hepatotoxic. So in August, as I mentioned, we began our effort to distribute vaccine among the homeless, and then after we did the emergency declaration, it was the outbreak declaration, it was much easier to mobilize resources. And then later in the fall, the state declared an emergency, and this was incredibly helpful to us because it will allow us to use EMTs. Our nurses have been aggressively going to shelters, feeding sites, and other locations, and they really are beginning to burn out because they also, have other jobs to do. I think as in San Diego, they go out with homeless outreach workers who know the community. They go directly to the encampments, or they go to other large sites where you'll see a lot of homeless congregating. We also offer free vaccine in all of our public health clinics. And then a big part of our outreach campaign has been sharing vaccine with partners, so community-based health clinics, hospitals, and particularly, again, based on the San Diego experience, the jail. We have the largest jail system in the United States with 14,000 inmates in it. And they have been able to distribute already 6,000 doses of vaccine, which is very good. I think the uptake among jail inmates is only about 50%. So they've really been offering it to almost everybody who's in the jail system. And so the total number of vaccines that has been administered or distributed to partners is more than 26,000 doses. Unlike San Diego, we don't have our own vaccine registry. We do use CARE, the California system, but it's not the sort of thing where people can use it in the field on their phone. So, a lot is being recorded on paper, and I think there's a backlog in data entry, and I do think that is a resource that we really lack here, and I think wish was stronger. The other thing we've been working on is trying to have beds for patients who are still infectious but don't need a hospital bed. This came up once or twice in the beginning. Interestingly, after we set it up, it didn't come up again. But patients who are sick but not so sick that they need to be admitted, we didn't want them discharged back to the street or back to a shelter. So although we're willing to have them go to a home, we wanted to have some beds available. So we worked with there's a housing system for the homeless that's run by DHS, and we worked with them to obtain 4 recuperative beds for patients who might need them, and that would give us some time so we could set up a more stable housing situation for them. As I said, that came up. There was one patient who was diagnosed in an emergency room and then sent out to the street before we could either interview them or sort of get them to some other place, and that's what motivated us to set this up. Since we set it up, we did have one patient who was diagnosed with hepatitis A who said that she was going to go stay with her boyfriend. We spoke with the boyfriend. We verified the address. And then, of course, when we went to follow up, there was no one living there by that name. So I think it shows that even when you set up all these systems, it can be really complicated. We've done a lot of outreach to our providers via the Health Alert Network. We ask that if they had homeless patients who were suspected to have hepatitis A, they call us even before the diagnosis. I would say that only happened a couple of times, but it did happen a couple of times, to facilitate interviewing, to facilitate the housing. And then our lab is also willing to do testing for hospitals that do it as a send-out, because that is an issue for some hospitals. Somebody will come in, usually when they don't have hepatitis A, what they have is alcoholic hepatitis, but you can't tell, when they're visiting, we're in the ER, what exactly is going on. So our lab is willing to do the test, usually within 6 hours, every day except Sunday. A lot of efforts have been made on sanitation. I think some of San Diego's efforts on sanitation have gotten a lot of press, which has been helpful to LA. Our environmental health went out and did a survey of homeless encampments in order to advise cities on where to place restrooms and hand washing stations. The county is working on placing them in the unincorporated areas. And the biggest issues around the bathrooms really is security and cleaning, but mostly security, I think. We've also worked with the restaurant inspectors to do outreach to restaurants and area businesses that open their bathrooms to the homeless to provide information about homeless and about cleaning. This was based a lot on talking to San Diego and their experience with where the homeless were using bathroom facilities. And although I think we all probably agree that the best way to stop the outbreak is going to be through vaccination, improving sanitation among our large homeless population feels like it can only help in terms of infectious diseases in general. We've also been trying to promote awareness about vaccination through the media, through social media. And we have palm cards that we hand out to let people know where they can go to get vaccinated. And we kind of thought through, again, realizing that we didn't have as many resources as we wished we had, since we luckily haven't had a massive outbreak. The goal was to, whenever there was a case, not only vaccinate directly around that person, but vaccinate the whole area, understanding that we don't always get good information from people who are homeless and potentially mentally ill to people use the term, we're using the word swarm, although then it felt like it wasn't a good word, but just to flood that area with vaccine. We did something similar in the jail when we had a case in our jail. We vaccinated not just the contacts, but also the secondary and tertiary contacts, because we probably got there a little bit late, and it was probably incubating among them. And so the idea was just to kind of hit a threshold of vaccination in a certain area to try to prevent an explosion to a larger outbreak. And yeah, so this was the case in the jail, and there were over 1,200 primary and secondary contacts that were identified. And although they weren't all vaccinated, a great effort was made to reach as many of them as possible. And we didn't have any additional cases that were related to that case. So that, as I say, is generally what we've been doing to try to stave off an outbreak. I think to a certain extent we've been lucky. And I wouldn't say that we're out of the woods given the way the outbreaks have been spreading around the country. And I'm hoping that we can continue the momentum at vaccination. We've vaccinated nowhere near as many people as San Diego has vaccinated, and we're much larger. So I think continued vaccination will help us in the long run, as I think this problem of hepatitis among adults is probably here with us for a while.
Thank you, Dr. Balter. We hope it's not too long. And you and Dr. Thihalolipavan painted a picture of what's happening in two villages, San Diego County and LA County. You've triggered a lot of questions, and to help with that is our moderator, Lisa Brill. She is the chairperson of the Education Committee as well as a board member for the CIC. If you've been waiting to ask a question, now is the time to insert your question into the chat box in the lower left hand of your screen. As we give time for Lisa to organize the questions, we'd like to take this time to remind you that following this program, an evaluation will automatically come up, and we would appreciate your responses. The California Immunization Coalition produces at least 3 education hours per year, and we rely on your feedback in preparing for these calls. I'd like to turn the mic over to Lisa now, as she will address some of your questions. Lisa, please take it away.
Okay, thank you very much, Eugene, and thank you for those excellent presentations. I do have 3 questions. I encourage everybody to go into their chat and send a question. Let me just see if any more of them just came in. Somebody asked, what is the extent of the epidemic in Santa Cruz? And also, you might want to touch base on this one too. I mean, it's what is the extent of the epidemic or the outbreak in the state as a whole?
I don't know if anyone from Santa Cruz. I don't know if anyone from Santa Cruz is on the line. The last I checked, they had more than 70 cases, which I remember on a per population basis did actually exceed San Diego in terms of rate, even though the sheer number of cases in San Diego is much greater. And I don't know that I can speak to the whole state. I don't know if anyone else can.
Somebody from the state on the line? Kathleen Harriman. Okay, I have some more questions coming in. Are the sanitation methods going to remain in place long term?
I can start. This is Sayone.
Even,
that's a great question, because I think that as long as there's an issue of homelessness and and people living in essentially these fecally contaminated environments where you're having a lot of unsanitary environments, I agree that vaccination is the best protection because they're going to be re-exposed to those areas. But as Sharon mentioned appropriately, that this addressing sanitation will help us with other diseases and potential other outbreaks. So we're not there yet in terms of ending the outbreak or anything like that, but we know that we do have to continue having dialogue with our cities who have the jurisdiction for sanitation, not the county. We have it for the unincorporated area, of course. We have to continue having that dialogue about sanitation and the importance of it for these vulnerable populations.
Yeah, and I just echo what Sayone says. I mean, I want ours aren't even all in place yet, I might add. We're still working on that. The system is a little slow. But, people are already saying, well, how long do we have to keep these measures up? And I am hoping that people understand that it isn't just hepatitis A, that, there's other things that we could have outbreaks of, and that sanitation is important.
And I'm wondering if I was curious about whether you got pushback from the community because you're putting sanitation, bathrooms, and hand washing and quote unquote encouraging them to come to my county. Was there that negative pushback?
I think that any time you introduce new things, whether it's services or for people, especially vulnerable populations that particularly have a stigma attached to them, then we always get some level of pushback. Given I think the amount of deaths and the media that this had gotten in San Diego, at least, that it was an easier sell. But we still, to this day, I mean, a couple weeks ago, we had someone was complaining about a hand washing station, and they didn't want it in their neighborhood. They thought it was attracting people. So we evaluate all these stations and if there's a true need, and we have said no to some requests for hand washing stations because we didn't think there was a need. And so we're able to justify, when we need to. But yes, we get pushback.
Yep.
Okay.
In LA, we're not, except in the unincorporated areas, we're not building them ourselves. We're encouraging the cities to build them. And I mean, we have part of the surveys by the environmental group was to sort of establish where the highest density of homeless and lowest density per capita of homeless hand washing stations were, and to say, look, you need more of them in these places. The bigger pushback I think we've encountered is that cities just don't want to spend the money on it. And it's as much the money for the security around them as it is, the hand washing stations and the bathrooms themselves are not the great expense. It's the security around them that is the great expense.
Mm-hmm. Okay. Well, thank you. Before we go on to some other questions, I got 2 responses from people in the state. Kathleen Harriman, all of you should have seen this. She said that there have been 18 cases in other jurisdictions and 76 cases in Santa Cruz. And then John Reichel posted something from Sarah Royce, CHTP, noting that we post case counts each week for the whole state, and the site is www.cdph.ca.gov. Okay. I have a number of questions that were more sort of clinical and about vaccination. Did you experience any problems obtaining the vaccine? Are you giving both doses or only concentrating on the initial dose?
I can start and Sharon can correct or supplement. For us, our experience was that initially we had no problems. At some point, maybe in the fall, that's when I think there was a lot more attention to the hepatitis A outbreak here and just nationally. And as you heard previously, there's other hepatitis A outbreaks like the MSM-focused one in New York City, or the one that's affecting disproportionately MSM. And then also there's international hepatitis A outbreaks and Michigan, as I mentioned. So there were some supply constraints, and particularly of the 317 funded vaccine. And so the state has been a strong partner in terms of trying to make sure and work with the CDC and make sure that we have access to the vaccine. But at some point there was a slowdown in the vaccine supply, and we were just concerned that we may not have enough for this county. So we went ahead and purchased privately several thousand doses, and that's been very helpful. But currently we're not having any issue, and the state has been nothing but supportive with that. And then
and I would just
hear.
Oh yeah.
Oh, sorry.
Why don't you finish? Sorry.
Yeah, sorry. And then the second question about giving both doses or concentrated initial. So because this is such an effective vaccine, giving one dose to as many population at-risk individuals would be effective in terms of containing the outbreak. But of course, ideally we'd want to give that second. We know that just as challenging it is to get the first, there's other challenges with the second. And this is not like, for example, the Hawaii outbreak where they had a foodborne outbreak a year ago, and then they did a press release 6 months later saying, hey, everyone, it's time for that 6-month dose. Because of the supply constraints, we didn't put out a second press release 6 months later because we know a lot of the people who got the initial vaccine were also people who weren't necessarily the population at risk. That said, for the population at most risk, the homeless, drug-using individuals, and those working most closely around them, we go back to many of those sites over and over again. So as we go back, we're able to see in the registry that they're due for their second shot, and we will administer it then. But the first dose by itself is 90 to 95% effective.
Okay.
Sorry, Sharon.
Thank you.
We had a slightly, I think, harder time with the vaccine, although I would reiterate that the state has been incredibly supportive. And it's not that we haven't had enough. I mean, we do have enough. It's more, I think, that we didn't feel like we could say, oh, everybody who wants it should get vaccinated. We really felt like we had to try to target our message and more aggressively limit the worried well. And even among providers say, if you have a lot of close contact with homeless, yes, you should get vaccinated. But everybody else, your routine providers, even in the public hospital, should be washing their hands. So I think it somewhat tempered our message, the concern that we wouldn't have enough vaccine. I have the sense that the supply is loosening now, and we've definitely, thanks to the state, really had enough. They acquired, I believe, the rest of the private supply of vaccine and distributed it, and that was incredibly helpful to us. And we've also focused on the single dose. There's a lot of data that if you can get a single dose into more than half of a community, you can really limit the risk of an outbreak. We don't have the kind of registry that San Diego has, unfortunately. So we can't necessarily go back and make sure that we're getting everyone their second dose. However, some people may be showing up for their second dose anyway. It also hasn't been 6 months since we started, so we're really not at the point of having, I think, to think that through.
Thank you. And
Thank
Sharon,
you.
I would just say I agree. Sorry, I just want to say I agree with Sharon that it did temper our messaging a little bit because initially we were saying, and there is that kind of clause in the CDC recommendations that says that anyone who wants to be immunized should be, and it was for good reason because there are groups that are stigmatized who are recommended, and so people might not self-disclose that they are, for example, an illicit drug user or men having sex with men or that they have chronic liver disease, things like that they may not want to admit to. But so we were kind of promoting that in the beginning, and then we changed our messaging to kind of deprioritize that promotion of that just because of the concerns about the vaccine supply.
I have a community question, and then we also have, a quick question about, someone asked, where is it? Is there a reason Hep A is more prevalent among males than females? That's one question. And then after that, I have a community-oriented type of question as well.
I think the risk factors are more prevalent among males than females. So obviously being a man who has sex with men is more prevalent. And then there are more homeless males than females, at least in LA County.
Mm.
Same here.
So in your population, it was, yeah.
Same here.
Okay. And the other question was, I was very impressed by all the different community groups that you've worked with, either, or there's a great wide variety of groups, either they were county affiliated or they were nonprofits or they were for-profit providers. Do you have any advice about how to coordinate with community partners or approach them, the best way to get as much of a win-win situation when working with community partners?
Yes, I'll start. I think we've learned a lot also in terms of working with certain community partners and some of our who work with and have that trusted relationship with a lot of the people who are most vulnerable in our communities. I would say that recently at the federal level they've released the Homeless Toolkit, which is good, and I would recommend you and your jurisdiction and getting your stakeholders together if you don't have an active outbreak, to think through like how do you work and get to the homeless population. But we worked, we happen to be a large integrated health and human services agency. Just about a year ago, summer of 2016, in that new fiscal year, we actually brought on housing into our integrated health and human services agency where it also had housing. So we're all under one leadership, us behavioral health, which has contracts with the substance use treatment facilities, or many of them, and then housing. And so it made it a lot easier to coordinate internally, and that helped us get to the partners that we can get to already that we have established relationships with. But then we have a regional task force for homelessness, and every HUD-funded county should have a continuum of care, and that's ours. It's called the RTFH. And so through them, we're able to, really have that continued dialogue with the homeless service providers and have separate calls and, meetings as needed. But I think that it was just invaluable having behavioral health partners at our table. We're not like LA or New York that has behavioral health within the health department, so we have to work separately, but having them within our agency, just like housing, was extremely helpful.
And actually, although we have behavioral health in our health departments, the housing agency is more of a nonprofit here. They receive funding from the county, but they're not a county agency. And so we work, there's more than one actually, and we work with them. And I think it has been incredibly valuable. I think to me, as somebody who's new to LA, it was also a chance to meet all of them early on, and because they are a group that has a lot of health issues. So it actually isn't all that straightforward here. I think in New York, there was an agency who worked specifically on housing, and that is less true here. So it was complicated, but definitely worth the time and effort, because not everybody trusts the health department when they show up and recommend a vaccine.
Thank you very, very much. I think that's about it for questions, because we are at 1 minute after 1. So I guess I'll hand it back to Eugene to wrap up, and also say a big thanks to the two of you for answering that variety of questions.
A very big thanks. We'd like to remind everyone that a recording and the slides for this webinar will be available at the CIC website. The address is immunizeca.org. And we'd also like to remind everyone to stay put if you can. After this broadcast closes, an evaluation will come up. A big thank you to Dr. Thihalolipavan and Dr. Balter for giving us updates on the current state of hepatitis A in California. And we would also like to thank the committee chairs, Lisa Brill, Meg Dorsey, and Kathy Gustafson, and the CIC Planning Group for coordinating this call. Finally, a big thank you to the County of San Diego Health and Human Services Agency, LA County Department of Public Health, and the California Department of Public Health's Immunization Branch. Thank you for joining us today, and we wish you happy holidays.